Our final speaker this morning is CEO and President of Recovery Innovations. Please welcome to the stage with his escorts for his TED-style talk, Mental Health Shouldn't Come with Handcuffs, Mr. David Covington.
Mental health shouldn't come in a police car. It shouldn't come with handcuffs. The police are here to protect, not to collect me. And yet, here we are. Consider I'm your father, and I've been struggling. I've been looking in that mirror and wondering about going on. And in my struggle, I reached out to a friend and confided in them what was going on. And what did they do? They called that 3-digit hotline, 911. 911 asks a question. They want to know what your emergency is. They want to know if they can roll a police car, an ambulance, or a fire truck. And in this case, my crisis went from one of the worst days of my year or my life to even being worse yet. So I'm going to ask these nice officers, one of them to uncuff me. Now, I had the privilege of putting my hands in the front. In real life, they're in the back. I wanted you to see those handcuffs. And normally, we don't get these amazing Larry and Eugene officers. We might get CIT-trained officers, but officers are not coming to bring care and compassion. That's not their basic approach. But in the perfect approach, it still feels like an arrest for most individuals. You're put in handcuffs, you're lowered into that police car, and I mentioned to a fellow law enforcement leader that, in fact, you weren't being arrested. You were just being transported to the hospital, to an emergency department. And she said, yeah, that's not the way most officers think about it. They think about, you're being arrested. They don't have the concept of least intrusive. That's not a comment for them. Now, how often does this occur, that someone reaches out for help? This is our crisis facility just west of downtown Phoenix. And this is during Christmas week. There are 5 police cars queued up there. Each of them is bringing someone in. They didn't go to a hospital. They brought them directly to the center. And in our experience, about 70% of those individuals come in handcuffs for treatment, for care, for support. So we've got to do something way different. We need a transformation. We've got to have a radical revolution. And we're going to do that. Officers, if I could get you to support my transformation here.
There we go.
There we go. All right. There we go. Hey, can we have a round of applause for our officers? The promise of 988 gives us a brand new opportunity to do things way differently. Now, what happens today is commonly people call 911. 300 million people a year are calling through that easy-to-remember 3-digit hotline. And we believe about 10% of those calls rather should have gone to 988. They're a mental health emergency. They're a substance use emergency. It's someone who's challenged with thinking about death. And they call this number, which rolls a car. That would be about the size of the population of Texas. 30 million people a year. And they land up getting a response that is far different. Now, I want to lay out a vision today of a system that is far different. And in order to do that, let's go back to the ludicrous way we used to do not a behavioral health emergency response, but a physical health emergency response. Let's talk about that. Now, this is the Atlanta phone book. For those of you who don't know what a phone book is, I'll ask someone about it. This is the front page inside, and you'll see it's really important. Emergency numbers, big exclamation point, and then it's got this really helpful. There's the number for fire and police and doctor. Actually, it's blank. If you look in the upper right, you're supposed to do your homework. You go through other pages of the phone book. You figure out which of those 10-digit numbers you're supposed to call. You write that in this space. You then tear that out of your phone book, tape it to the refrigerator, and have your emergency in the kitchen. That's the sophisticated way we used to do it. The first 911 calls were answered in 1968. Let's go 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 1980. One of the most famous people in the world, in the largest city in the United States, right off of Central Park, and John Lennon is shot in the back 5 times. Bystanders do what? They call 911. But there's no ambulance capacity available. How is he taken to the hospital? In the back of a police car in 1980. Now, would John Lennon have survived had he had ambulance care on the scene and emergency transportation? We won't know, but he wasn't saved by putting him in the back of a police car with officers trying to do their best for their mission of public service, public safety, and they're roped into other things because we don't have the capacity that we need. But in the 50s and 60s, if you got to a hospital, emergency departments did exist, but they weren't like today. Today we just waltz right in and we're seen. And if we're not seen for an hour or 2 or 3 or 4, it's a big story and we think about it and talk about it. But in the 60s, Dr. Sandy Schneider, past president of the American College of Emergency Physicians, reminds us that there was a locked door. I've over-dramatized the bell, but there was she called it a dongle that you would ring. And either someone would come to that door or they wouldn't. But if they did come to that door, they were going to ask you, is your physician on panel with our hospital? They were going to want to know other things. They didn't consider you a patient unless and until you were admitted. Now, I was at a planning meeting for 988 2 years before it went live. And Dr. Sandy Schneider said, this is what behavioral health emergencies look like today. Barriers, leveraging law enforcement, putting our public safety and hospital people in a position that they weren't trained for, and giving support to people on their worst day that feels more like punishment. Now, how could we get from there to where we are today? Where an ambulance could be on the scene here if we have a medical emergency in this room, someone calls 911, it's likely an ambulance will be here in 3 or 4 minutes. Maybe faster, given the convention center. They'll do treatment on the scene and get us to an emergency room if more treatment is needed, where there'll be rapid care. That happened because in 1966, a report came out, Accidental Death and Disability, the neglected disease of modern society. And it didn't call it 911, but it called for better coordination and communication through an easy 3-digit hotline. It called for ambulance response. It called for emergency departments that were directly accessible. And it did that by referencing Vietnam. And it tracked those who were injured on the battlefront in World War I, World War II, Korea, and Vietnam, and how every war we got better. And if you were injured on the battlefront, the likelihood of your surviving got doubly better, and doubly better again. Until Vietnam, it was around 2% who ended up passing away because of the medics. If you were alive on the battlefield, the medics got to you quickly. They did treatment on the scene. Remember those MASH? Again, MASH. You don't remember MASH. Never mind. But there was this show. And these helicopters would ferry you on the side of They got you to a trauma unit where surgeons were standing by. And the authors of this report said, you are safer being in a Jeep accident, having a heart attack, getting shot. You're safer on the front lines of Vietnam than you are on the streets of St. Louis. And it's time to do something different. So we did. Now in 2013, Governor Hickenlooper and the Colorado legislature were reflecting on the Columbine tragedy, and they were reflecting on Aurora. Now, most people don't know the story, but the Aurora, the individual who was involved in those shootings, stood outside the movie theater after he had already prepared the scene, and he decided to do one last check on whether he was on the right route. And he called the local crisis hotline. Now, he was on the phone for about 8 seconds, but did not get an answer. And then proceeded into the theater, and 30 individuals died. Now, we'll not know whether or not a call taker could have averted such a tragedy. But we know not answering that call did not avert that tragedy, no more than John Lennon not getting an ambulance. And an individual named Chris Habgood from the Colorado Department of Health Services led a team that said, let's do something different. They did a national environmental scan, and they began to think through, what if we had a behavioral health response that mirrored what we have with emergency medical, a 3-digit hotline, the equivalent of that ambulance, treatment and transport if needed, and the equivalent of that accessible emergency department, a crisis receiving facility. And they laid out a blueprint in 2013 for doing something far different. Dr. Brian Hepburn and the National Association of State Mental Health Program Directors, the State Mental Health Commissioners, picked up on that idea in 2017 and began the Beyond Bed series. They began thinking through, what if there's no explicit threat to public safety? We shouldn't be involving the cops. There's no overt criminal activity, no police. There's no obvious physical health medical emergency, they don't need to go to the hospital for medical clearance. They get a behavioral health response straight away, as fast as possible. So just like 911 and ambulance and emergency department, someone to call, someone to come, and a safe place to go if needed. In 2020, SAMHSA distributed the national guidelines for behavioral health crisis care. And they began to think through that concept. And 2 years later, we have 988. 988, potentially the most transformative opportunity in behavioral health in our, maybe since dehospitalization. Again, ask someone, they'll tell you about it. 988 is beginning to think through the next steps. The FCC is now looking at geo-routing. Unfortunately, I still have an Atlanta phone, and if I'm in Phoenix and I call, I'm going to get behavioral health link, Michael, in Atlanta. The geo-routing will move it toward looking at your exact location. I'm here in St. Louis. It will get me through to the St. Louis or Missouri crisis line. In 2014, a woman in Atlanta actually accidentally had an accident, drove into a lake. She was submerging and she called 911. But at the time, just 10 years ago, the technology was the nearest cell phone towers were triangulated and it gave an approximate position. But there were multiple 911s in Atlanta. There was confusion over response and she passed away. Tragically, when it could have been avoided. It's about the speed. If there is a marathon in your city, the death rates will rise because the ambulance routes are elongated. This is about how fast. So Congress passed a law that the 911 would get your precise geolocation and we could get to you faster and provide a support and response. So someone to call someone to come, a mobile crisis team, not individuals in white coats or marked vehicles, but coming more along. I'll use Erica Chestnut Ramirez is here, her phrase, like two old friends, coming out, a clinician, a person with lived experience, a certified peer, providing support, getting down and engaging that individual in the moment and directly and with care. We found that if a call center, a 988 center, has access to these kinds of teams, it's 5 times less likely that police will be engaged. It's 4 times less likely that a hospital emergency department is going to be the next step. And these are not just solutions for metropolitan areas. Georgia, for a decade, has been sending these teams to every county of all the rural areas across the state. This is emerging as the best practice, and it becomes the alternative. Now, will there be times that there is a threat to public safety, and we have to coordinate with police? Of course. But the vast majority are something different, and you get there nonetheless. Now, officers have deemed this, what happens in our current system, as wall time. They handcuff not out of some, nefarious kind of idea. It's protocol. And so they're taking the person to the emergency department where they get caught. They can be there for 4 hours or 6 hours or more. It's just standing up against the wall, hoping the hospital staff looking to them to be potential support, attending, and transportation if needed. But Major Sam Cochran and the people behind CIT in the 1980s conceived of facilities that would be directly accessible without going to the hospital first. Again, a transformative sort of idea. And is this something that can really happen? Is this something that can occur? This is the facility that is coming up in Columbus, Ohio. And I think Jonathan is sitting right there, the architect behind this facility, that will be able to serve dozens and dozens of individuals and have law enforcement come directly. A similar facility coming up, funded by the Huntsman Family Foundation in Salt Lake City, Utah. These programs will open this year or next. And we're starting to see these around the country. It's a simple concept. A behavioral health emergency warrants a behavioral health response. I'm going to channel Kevin Hines. Say it with me. A behavioral health emergency warrants a behavioral health response. The police don't want to be in this situation. They're our partners and supports. We've got to full scale these solutions. We've got to bring a radical approach. It's time for care in a crisis that feels like care to the individual. It's time for the promise of 988. Thank you.